Hello and welcome to the Medical Affairs Dialogues. We talk a lot about value based care and outcomes, but there's a bigger question here. Are we truly measuring what really matters in healthcare, or are we measuring what is easily trackable? These are the kind of questions we are going to ask our guest today. Our guest and our esteemed guest for this episode is Professor Susanna Gallani. Welcome to the episode, Susanna.
Thank you. Thank you so much for having me.
Yeah, before we begin, I would love to introduce you to my audience. Susanna Gallani is a professor at Harvard Business School who also teaches at the Harvard Medical School. Her research focuses on performance management systems, particularly the balance between monetary and non monetary incentives to improve behavior, reduce burnout, and enhance healthcare value. She also explores the role of AI in supporting provider well being and advancing health equity, including addressing social determinants of health. Thank you, Susanna, for agreeing to be a part of this episode. And I'm so glad you are here.
I'm so honored to be one of your guests. I look forward to our conversation.
Yes, we have a very interesting discussion ahead. And the topic for today is: are we measuring the right metrics? The future of outcomes in value based healthcare. Susanna, before we begin our conversation, I want you to connect with my audience. I want to open this platform for you to share your career journey, your stellar career. How did you create this? What it took to overcome the challenges I'm sure that you encountered while creating this career. So share it with my audience, please.
Thank you. That's very kind. It's a long journey, and it's a very strange journey because I never thought if I were to talk to my 16-year-old self and tell her that I would be talking to you today on this topic as a professor, an associate professor at Harvard Business School, I would have questioned the mental health of the person that was talking to me. Because I grew up in Italy, first of all, so that explains my accent. And I started in the bulk of my career was for a company that is well known. It's Honeywell International. And I worked in manufacturing. So really, really not connected with healthcare and the work that I do today at all. And then for a number of reasons, I ended up falling in love with academic research. So I changed career, pivoted out of industry for an academic career. And I did my doctorate at Michigan State University. Technically, I am an accounting professor, which is also a little bit strange. But when I speak a little bit more about my work, it will make more sense. And finally, when I joined Harvard Business School, although some of my work in my doctoral program was already connected to healthcare, because I was very, very fortunate to have an amazing advisor, Professor Ranjani Krishnan, who was doing a lot of work in healthcare. So she kind of socialized me to the healthcare world already. But then really the pivot happened when I joined Harvard Business School. And I met, Professor Bob Kaplan, who invited me to be part of a number of courses, and I started knowing more people that work in the industry. And because of my interest in incentives and performance measurement and performance management, once you see what is going on in healthcare, it's really hard to look away. And I felt there was an opportunity to really do better and to import some of the lessons that we have learned in other industries into the world of healthcare for the betterment of everyone, provider and patients alike. So I've been blessed. So yes, there were challenges, but there were challenges that led me to great things, because I am honored. I have to pinch myself every once in a while to realize where I am now. And although I have a long way to go and much work that I want to do more, but I am surrounded by an amazing faculty. I have the privilege to teach amazing students of all ages, not just our MBAs, but also our professionals that come here for education, both at the business school and at the medical school. So it's been a privilege, and I have much more that I want to do, but looking back, it's been a good run.
Absolutely, we know it, and I know you for some time now, and I can vouch for that. We have so much to accomplish, and I'm so glad that we connected and connected how, and here we are together collaborating on this podcast. Susanna, Through this discussion, I want to explore how value based care is reshaping healthcare. And that's why we've gathered together here. Is it focusing more towards better outcomes for patients, or is it just adding more treatments? And I have been partially and from very closely seen uh, the healthcare system, how it operates, and I'll tell you how in the later discussion. And these questions emerge and stem from that. So the first question to you: we know that financial incentives, if tied to metrics, may shift focus towards compliance rather than meaningful outcomes. So my question is, how value-based care has it become more about hitting metrics, or is it just actually about improving patient health? What are we
This
focusing right
is,
now?
yeah, this is such a deep question. So as you know, the value-based healthcare in the way that we talk about it, it was codified in 2006 by Michael Porter and Elizabeth Theisberg in their famous book that introduced this idea of value-based healthcare. And because I teach a lot of courses that are based on the book and the work that has ensued from it, what surprises me is that we have lost a little bit the meaning of that idea, of that framework. In fact, the book positions the value-based healthcare framework as a strategic approach to healthcare. But now, in the day-to-day talk with practitioners, with physicians, with administrators, when you talk about value-based care, they think about a payment model, which is important. It's really important, but it's not the whole page. There's much more to the framework. There's an approach to healthcare delivery that needs to happen, reorganizing healthcare around conditions and around patients, aligning incentives throughout the value chain of healthcare, and supporting organizations with appropriate information systems that can actually measure and give feedback and input and information on what matters. So it has reduced, maybe to some extent, to a just trying to reach the metric for which I am paid. And I think that's a little bit problematic. And it's problematic for two reasons. One, if we just attempt to meet the metrics, but we don't change the delivery, we're very likely to make really incremental minor contributions to better outcomes. And that is starting from the assumption that the payment models actually reward organizations for better outcomes, which is a big question mark, right? That's something I'll expand on in a little bit. But the problem is that we actually have to change how healthcare is delivered. And while there are many, many, many efforts to do so, I'm not saying that nothing has been done. I don't think that has been a pervasive movement as
Mhm.
we expected it to see. Part of that is because the payment models are a little bit slow in catching up. There are some enlightened payers that really want to support better outcomes, and so will reward organizations for doing so, but not as many as we need. We need more effort. We need more momentum in that direction. Sadly, we are still very much anchored in the fee-for-service world. And moving away from fee for service is really difficult. It's technically very challenging because all of our systems, all of our routines, all of our payment models, all of our reporting practices are really anchored on that structure. So ideally, one would do away with it and start fresh. But obviously, we don't have the luxury of doing so in an industry that needs to continue servicing patients and seeing patients day in, day out. So this leads me to the other problem, that we don't measure outcomes particularly well. It is really, really difficult to do because patient outcomes, obviously, there's different layers to a person's health. And we have a pretty good handle on some clinical outcomes. There's lots of measurement. Hospitals measure millions of data points
Mhm.
every day. But then it's the insights that come from those measurements that I think could be improved.
Mhm.
And we don't have a good confidence that what we're measuring in terms, and we call outcomes, is really what the patient experiences as outcomes. And so I think that that is where I see the need for much more investment in terms of effort, in terms of technology, and what I think will return us to the original idea of generating value for the patient.
Yeah, you've hit the correct points here. I think I am aligned with that. Coming from healthcare background, I'm aligned with that. I'm not sure if the patient sees the same outcome as the provider is intending or the care delivery team is intending. So we want to explore more on that. So, like you were saying, metrics, right? Millions and millions of metrics being measured. An overload of metrics can overlook patient priorities like quality of life, daily functioning. These matter to the patient. So, my question is, are we over measuring healthcare, tracking dozens of KPIs while missing what truly matters to the patients? Please go deeper and granular on it.
Yeah, yes and no. So the answer to your question is yes and no. I think we're measuring a lot. There's a friend of mine who says hospitals are data rich and insight poor. And I think it is because we're measuring so much, but I'm not comfortable saying we should measure less. What I will say is that we should look at less things or aggregate some of these millions of data points into something meaningful
Mhm.
more intentionally than we currently are. And I'm going to nerd out on you for a second, okay? And just go back to my theoretical upbringing as a doctoral student. And there's a lot of research done in incentive and compensation, and there's economic theory behind it and behavioral theory behind it. And one of the things that we know from lots and lots of research done by people that are much more, accomplished than I will ever be, is that when we select certain metrics and we hold people accountable for those metrics, either because we link them to their compensation or simply because we look at them and we go back to them and say, please explain your performance against this metric,
Mhm.
we are very powerfully communicating priorities to the recipient of that message. So when we decide we're going to look at length of stay, for example, which is a very common measure in healthcare, and we're saying we're going to focus on reducing length of stay, which is a really important thing to do. I'm not questioning the intent, but I'm saying you're now telling me that length of stay is more important than, let's select another aspect of healthcare, I don't know, patient satisfaction, because you're not holding me accountable for that. Or return to work for somebody that is discharged from the hospital, because we don't measure that, or maybe we measure it but we don't look at it. So we
Mhm.
have to be very careful about the message that we communicate, and this has two problems, at least. One is that we are, as I said, creating priorities somewhat unintentionally sometimes. The second problem is that this prioritization, if it strides against the values of the healthcare provider, of the physician, of the nurse, if this feels like it's not the right priority, it creates moral injury, it creates moral disconnect, and it leads to burnout and dissatisfaction and confusion. And this is not a good place to be when you're trying to deliver healthcare, right? We have to remember
Mhm.
that without providers, there is no value to be delivered. They are like the fundamental element for value creation. So this is why I think it's really important to be very intentional about what we select among those metrics, those millions of metrics that we have. Let's select those that are not simply easy to measure or easy to grasp, but they're also really meaningful for what we are trying to do. Together with my colleague Irene Georgescu, who is a faculty member at the University of Montpellier in France, we're actually building on this idea, and we're developing a line of work that we call mission-driven management. And what we're recommending is that we introduce a test as to validate the appropriateness of certain metrics. Do they speak to the mission of the organization in a traceable way? And this is applicable to all industries, but we're looking at it within healthcare settings. So for example, when we look at length of stay, is this a metric that we can reconduct to the mission of the organization in a meaningful way that can give everybody line of sight as to why we want a shorter length of stay? This has two implications. On the one hand, it might help us select better metrics. So among those that we have available, let's start from those that really speak to the mission and maybe de-emphasize those for which the link to the mission is less clear or less direct. On the other hand, it can also help us justify why some metrics that may feel uncomfortable or not kosher enough, if you pass me that term. For example, financials, right? Financial performance. People feel uncomfortable when you hold them accountable for financial performance. But at the same time, financial resources are fundamental for the mission of the organization to continue to be delivered. So can we put this in a context and in a structure where it makes sense and it doesn't create that striding effect between the values of the physician and the metrics that they're held accountable against? So back to your original question, I think we're measuring a lot, and we're measuring a lot of the right things, but we're also measuring a lot of things that we can't justify why we measure them. It's just that it's easy to look at them, or they speak to a question that somebody may have. I think we need to kind of take a step back, and among all these metrics, we need to start assessing how well these metrics, especially when we hold people accountable for them, and especially when we pay them for it, really speak to the mission of the organization, which is to create value for the patient.
Love that. Love that. Yes. I'm so proud of you, the work you're doing.
You're very kind.
And and I want to switch gears here and focus on the providers as well. Because like you said, they are the biggest stakeholders here for delivery. And we have to focus on them as well. So standard metrics often fail to account for social and clinical complexity, creating potential inequities. My question is, does current outcome metrics unfairly penalize providers who serve more complex or underserved populations? Do you see that? Do you see that in your research? What is your perspective?
So I think the answer is probably yes, but I'm not sure that there is a straight why. So the idea is, we know in the data everybody sees disparities, right? And we typically see that hospitals or healthcare institutions that serve less affluent populations tend to fare less favorably financially. They tend to struggle to make it financially. They safety net hospitals are always at least in the vast majority of cases, are hospitals that don't have much extra resources, right? And that is in part because they deal with an underinsured population, and so they don't have as much incoming cash as they need to consume to treat the patients that they serve. So there is, however, when we think about metrics, I could imagine the counterpoint to this statement that there is penalization. The counterpoint is there is risk adjustment, right? So the question now is, are we risk adjusting correctly? Are we including in that risk adjustment the elements that make that patient socially and clinically more complex? So it is a little bit at the core of the payment structures. And one of the things that has always baffled me as one that comes from outside of healthcare is that we pay less for more complex people. When we look at it, right? When we look at it and we look at the socially and medically complex people, these are our prime customers of our safety net hospitals. And if they generate any revenue, they generate not enough revenue to pay for the resources that go into their care, generating therefore a wealth transfer between the insured patients and toward the uninsured ones. So I've always been questioning that assumption. Like, wouldn't it be better to actually pay more for those people that need more care because not
Mhm.
only they have more complex conditions, but they are um, also less likely to succeed in their care plans because their social and structural condition of life are not conducive to a successful outcome. Now, this may come across as very naive, right? I can imagine people in the industry looking at me like, of course, we've said this for decades, and we all know that this should be good, should be true, but we can't do it because economically that doesn't work. So I have a secret dream of documenting empirically what I call the business case for health equity. And I am approaching this from a purely scientific perspective. I want to just say up front, the moral imperative for me personally is enough, right? To provide care to the uninsured, to the underprivileged. I think that is the right thing to do. But that is a belief and a value that I hold. And as a scientist, I cannot use it as a justification for a conclusion, right? So if we want to do science, we have to use scientific methods. And I haven't been able to do it yet, but I strongly believe that it is possible to show that taking better care of the underprivileged from a healthcare perspective is actually very favorable, very conducive to good financial outcomes, not just for the institution that takes care of them. That's pretty simple to imagine, right? Because they obviously have a cash outflow to take care of these people that they will have to take care of anyway. And it's not matched by a cash inflow through an appropriate payment level. But let's imagine, let's expand the view to their social contributions, to the what they can be as members of our community, to the fact that them being more healthy, them being this underprivileged member of our community, our neighbors, if we can make our neighbors healthier, that makes us healthier. And so that leads us to be more productive members of society. And so there is an immediate benefit in the economics of the institution, but I think there's a societally relevant economic benefit of having people that can then be productive members of society. And not that this is the first order of importance, but they end up paying taxes, which then get reinvested in the community, right? So I think there is a way to show that the math works. I just need to find the right data to show it, but it is a firm belief that I hold. So as a scientist, I want to test this hypothesis.
I love your secret dream. And I hope that we someday get that mathematical equation to prove it because this will be huge. Huge value, huge impact. Um, Let us talk about the metrics part again. So today's metrics are system driven, like we are saying it. Patient led definitions could shift priorities significantly. So if patients are defined as value, which through our conversation, I guess our audience will see that they are value, how different would our healthcare system and its metrics look today?
I think we go back to the idea of what do we aggregate as data points into information. I don't think we are so disconnected because doctors see patients, they want their patients to be healthy. I don't think that is diametrically opposite. So I don't think we need to burn down the house on this particular aspect of healthcare. But I do believe that there needs to be more of a collaboration between the patient and the provider in deciding what success looks like.
Mm.
And ideally, for me, if we go back to the core of the definition of value, it needs to be having this, having providers contribute to the attainment of patients' goals. For example, if we take two breast cancer patients, and this is an example I have heard from Dr. Andrea Pusick, who is a physician at Brigham and Women's Hospital,
Mhm.
well-renowned breast cancer surgeon, and she has devoted a lot of her work into patient-reported outcomes. And the way that she speaks up, she's been very successful in collecting and implementing patient-reported outcomes in healthcare delivery. And the way she talks about it, she always brings this example of these two breast cancer patients that she had. And one was an older lady that had been an athlete her entire life. She was a rower and she didn't care much about her physical appearance, but in undergoing breast cancer surgery, the mastectomy, she really cared about her functional abilities and being able to regain her full function so that she could do the
Mhm.
things that she loves doing, which
Mhm.
in her case was rowing. As another patient, right about the same time, was a younger woman, and she had just been recently divorced, and she felt like she was ready to find her next partner in life, and she wanted to look good
Of
in,
course. Mhm.
undressed. And so that was important for her. So there
Mhm.
is no judgment on what should be important. And there is the physician should not be the one that determines which
Mhm.
should be the highest priority between these two. So as Dr. Pusick suggests, she asks that question up front so that then that informs her approach to the surgery, and she can make those choices when those choices are available to
Mhm.
help the patient fulfill their goals. So for me, this is kind of the missing link that Dr. Pusick has been very good at connecting, but in many ways, we are told that we are healthy, but do we really feel healthy? Is our functional life, is our social life reaching that point where we feel we are healthy? Even if our clinical outcomes look great, stellar, right? So
Mhm.
you had a really good hip replacement on paper. Your clinical indicators are all where they need to be. You can go
Mhm.
up and down the stairs. However, maybe you don't feel like you trust your hip so much to go hike that trail that you wanted to go hike by yourself. So these are the elements of health that I think we're not capturing particularly well today because they're really difficult to capture. I'm not faulting anyone for this. It's just that we're not there with the technology to be able to do this and integrate this picture of a person's health that has more of the pieces of the puzzle. Right now, it's like somebody gave us 1,000 pieces puzzle and we only have a handful of tiles. But we
Mhm.
can't really see what the picture is like until we fill in the rest of the tiles. Some of that is through patient-reported outcomes, which is a huge, huge, huge important signal and source of information. However, they're really difficult to collect because they're very costly in terms of structure, information. Patients need to put a lot of work, right, into communicating with their providers what their patient reported outcomes are. They might have a dedicated app, like we need another app for anything, right? So then the physicians get this influx of data that they don't always know how to incorporate in their
Mhm.
care plans or in their diagnosis. Plus, they don't get paid for it in a number of times, right? So the barriers are there. So my hope is that with advancements in technology, and I am very hopeful, you know this of me because we've talked about it in prior encounters. I am really, really bullish on the role that AI can play in helping us collecting this data in a more systematic way and also in a more longitudinal way so that healthcare measurement is not so episodic.
Yeah, totally. I'm aligned, and I am hoping the same. And also, I would like to add here that follow-ups, right? Following the patient. That data is so crucial. We understand, we talk about it, but it's missing. With my clients, I do a lot of clinical trial retention, patient retentions, and I see for an enrollment for clinical trials. But what is missing is the follow-ups, that
Mm.
data. So I really want to flag it out here. We need more data, and I am very, very stubborn on that AI should help us get more data on following up the patients after years of getting that treatment, participating in that clinical trial. I need that data, and we need that data for a better healthcare system and a more robust healthcare system. So, with that, and we have touched upon AI already, I'm going to piggyback on that. AI can improve insights, but may also reduce transparency and raise concerns about bias. With my partners, with my clients, I know there's an invisible barrier of trust and adoption barrier. So my question is AI going to fix outcome measurement or make it more opaque and harder to trust in this setting? Because your view really matters, because you are adding a different lens and your experience comes in. So please talk to us about this aspect. Is it going to get more harder to trust, more opaque, or is it going to be more transparent and easier for adoption?
Yeah. Big ethical question here. So the idea here, let me put it this way. Does AI have the ability to solve this problem? Yes. In theory, as a machine, does it have the cognitive power that we miss in order to be able to put together all these different data points? If given access to these data points, would it be able to do a better job than we currently do in augmenting the physician? Because I want to be very clear, I'm not ready to delegate this to AI without human intervention. I'm thinking about an
Absolutely.
AI physician team. Um, Technically, yes, I don't think there's any doubts that technically it can do it. But, and there's a series of buts here, right? So the first but is bias, because the as you mentioned, the what we get out of AI is very much dependent on what we put in to AI. And so having those biases that are already well documented in the data, that we know that there's underrepresentation, for example, in clinical trials, like you suggested, there's underrepresentation of certain racial groups, of certain members of society. And so we would already start with a set of training data that is slanted toward certain portions of society and not others. Plus, there's the trust. And trust is a big word and probably one of the biggest issues we have in healthcare, because there is a need to improve trust at any level, in any relationship between the physician and the providers, between providers and payers. I could go on. So where does trust come from? It comes from, one, verifiability, and it comes from ethics. So ethics are also informed by good governance, right? So, and governance leads us to regulation. So, to make a long story short, I think there is a lot of work that needs to be done to make AI trustworthy. What I really, really yearn to see, what I'm not seeing and I want to see more, is an urgency in really tackling the governance aspects of AI before it's too late. Right now, I see a lot of reactions in the social media, in the public press, in on TV, or talking to people, as to documenting that we're very scared of what AI could do if misused, right? We're all scared of that. The people that build it are scared of that, right?
Mhm.
But where is the reaction? Where is the think tank? Where is the task force? Where is the effort of getting ahead of it? It feels a little bit like societally we are either giving up on it and say it's going to destroy us and we're okay with it, which I'm not ready to accept
I'm
that.
not.
Or we are also putting our head under the cover and say, well, maybe it won't happen. It will happen. And so I am really urging everybody I talk to start thinking about it, because it is moving so fast that it will likely get away from us. So with this big caveat that we absolutely need a handle on the governance on who owns the data. As I mentioned before, if we could give AI access to all the data points that it needs, which includes our wearables, it includes our transactions, it includes our web searches, right? Those are all informative of our health in one way or another. But imagine that there would be somebody that has access to this wealth of information of one person. That is too much power to left unbridled. We absolutely need to have a handle on who is going to govern this data. How are we going to limit the misuses? And I am, this is the part that makes me the most afraid, because I don't see an urgency. Maybe it's there and I just don't see it. I want to be clear. It's not that I have all the information, but I would like to see more of that conversation going on instead of, you know, trying to stop this wave. The wave is coming. So back to your question about how do we, is AI going to be engendering more trust or less trust? If we do it well, I think it's going to be really powerful, because first of all, it would give the patient themselves access to a measure of health that they can believe and they can understand. Because right now, imagine, we all have been in the position. You're a physician, so you probably have less of this. But when I go take I don't know, a diagnostic test, and then I get the results in my patient portal, I understand 10% of what's written there. I have no idea what I'm reading, right? I need to wait until my doctor calls me and explains to me if that particular word that sounded really scary is really something I need to worry about or not. But let's imagine a world in which your measure of health is actually understandable in layman terms and actionable, so that you can take ownership of your own health and make choices before you need to delegate your choices to a physician. So my dream for the future, and this is not something that's going to happen tomorrow, but I would love to see us going in that direction, where the information about a patient's health resides first and foremost with the patient, and the patient then has more agency to interact with the healthcare system and the providers, where there is alignment between the goals of the system and the goals of the patient. And I want to say, my big statement on this is always, if we fix outcome measurement, we fix healthcare. I strongly believe that. Everything else, the payment models, the incentive that are misaligned, the fragmentation of healthcare goals and strategic goals, it would all fix itself. Because right now, we don't know what we're buying. And so if we could measure outcomes, which is the ultimate performance measure for healthcare, I strongly believe everything else falls into place.
Love the bold statement and the overarching theme. Oh my gosh, yes. And I also want to add here that I would not, I'm not ready to say that AI should take over. I want the human in charge. And I want to embed that in every human being that I speak to. Do not fall prey to the hype. Make sure human is in charge, not human in loop. Human in charge. And that's where I think the needle will move, which is better outcome, better healthcare.
Absolutely. As I
Love
always
it.
say, there's
Yeah,
no more human experience than being a patient.
absolutely. So, digging more into the metrics, some metrics persist despite limited relevance, driven more by habit than impact. What's one widely used healthcare metric we should eliminate right now? And my question is, why is it still existing? Why is it still being used?
Oh, I don't know. I don't know that I have a good answer for you. I would suggest, though, in the spirit of the case method, which is how we teach here at Harvard Business School, we don't give answers, we give questions, right? The questions
Mhm.
are our tools. So I want to link this back to what we were saying earlier. I don't know that there is a metric that we need to eliminate. I think we need to test the significance of every metric that we use. Because me coming out with a blank statement of let's get rid of this particular metric,
Mhm.
I think it's not a good idea. I don't think it's appropriate because somebody, they say that you don't remove a fence until you know why it was built in the first place, right? So I would want to do that exercise and say, okay, let's take this metric and why do we measure it? What does it tell us about the patient? What does it tell us about the effectiveness of the treatment? What does it tell us about their social determinants of health? And if we can't answer those questions relatively quickly, then maybe that's a candidate to be on the chopping block. But I would rather introduce a method than an actual list of metrics that should be chopped off.
Beautiful. Yes, I think I love what you said because we don't know moving one metric, what is, how the ripple effect follows. And that would not be visible in our lifetime because, like we said, there are so many things that we don't follow and we are not having data. So that would be risky. I love your response. I don't want this session to end, but I will be respectful of your time. This is my last question to you, Susanna. And this question and all the questions, like I said, I've curated because I've been a pediatric oncology scientist at the Cancer Institute in New Jersey in my past career. And I have very closely seen personalized care. And this question specifically stems from that. Personalization challenges standard definitions, raising questions about who defines success. So, my question is when healthcare becomes fully personalized and predictive, and that's what every healthcare professional wants, we want to make it more personalized, more predictive, more curated for and specific for the patient. Who decides what's a good outcome? Is it the algorithm? Is it the provider? Is it the patient? Please elaborate and kind of talk to us. What should the mindset be? Because we are so obsessed with personalizing care for a patient. It's good, but it is a two-sided dagger. How do we use this beast and how do we
Yes,
tackle it?
yes, yes. The straight answer is always the patient first, but not the patient alone. And especially not a single patient, right? Let's think about personalized medicine as we think of precision medicine, for example,
Mm.
right?
Mhm.
Which is a huge advancement in medicine because we can really take care of that one type of cancer that this subgroup of people has and not treat it with a blunt instrument as we used to before we made these advancements. I think of the future of healthcare and the future of outcome measurement as an expansion of that logic. Like, can we get more personalized in how we deliver care? But again, we can only know if something is working if the patient is healthy. And so we need to measure the patient's health and we need to be ready to measure it in a way that takes into account that every person is different.
Mhm.
My mentor, Professor Bob Kaplan, always said, people are not Toyotas, right? They don't come out of an assembly line. They don't all look the same. There's so many complexities in their health and their lives that we need to account for that. So for me, personalization needs to speak to this individual characteristics of the patient. However, while we are very different, we are not so different that we need an individual plan for every patient. What we can learn from aggregating all of these individualities and putting all these individual special unique data points together is trends, right? patients like you with your characteristics typically succeed with this particular treatment. We can't, at least not now, have an individualized plan for every single patient stemming from the individual characteristics of that particular patient. But we can have a much better idea of what we're doing today about how patients like the one we have in front of us today might or might not succeed for the particular course of care. So exactly what we do with precision medicine, right? So this particular presentation of breast cancer typically responds well to this type of treatment. And I think we need to expand that logic to healthcare. So in a nutshell, I think the patient's perspective and the patient's perception of value needs to be the starting point, but it needs to be aggregated in a way that we can generate some generalized learning as to what works and what doesn't for those particular clusters of patients that are similar enough to support the idea that they could be treated in a similar way.
Yeah, very, very impactful. Thank you, Susanna, for taking the time out for talking to us and beautifully curating these responses. I'm very sure my audience will love these responses and they will find this session very, very impactful. So, thank you for bringing so much information, so much insights, so much, um, you know, uh, energy to the conversation and real impact to the conversation. I thoroughly enjoyed our discussion.
Thank you so much for having me. The time has flown away, so I'm really, really happy that we had the opportunity to connect. Thank you for inviting me.
Yeah. Thank you all for joining us. Remember, what we measure shapes the care we deliver. To move forward, we need to think more about and focus more on counting less and then measuring more on what really improves patient lives. I'll leave you all with that thought. Until next time, stay tuned, stay informed, and stay engaged.